Okay, by my watch, it's 7 o'clock. We'll go ahead and get started. Well, welcome to, I think this is the 13th program of Children's Heartbeat. So we've been doing this exactly from about a year ago. We started in December of 2020 is when we started. And we've got a great program lined up today. So first of all, thank you everybody who's here and who's going to be joining soon. I want to thank the presenters. Today's presentation will be from Dr. Jennifer Shortland and Dr. Shu Sanatani from BC Children's in Vancouver, British Columbia. We have two designated experts today, Dr. Andrew Landstrom and Dr. Allison Hill. Dr. Landstrom is from Duke University. He's already been here before once. And Dr. Hill is from Children's Hospital of LA. There's a few other PACES members who are joining, which is fantastic and great to see. And this map shows you the different countries from which people have attended this program so far. We've had 50 countries. We're hoping to grow further. So one request to all the participants is that if you like this program, please share it with your friends, ask them to attend. The goal of this program is to bring pediatric arrhythmia education worldwide and make it as resource. So the next thing that I will say is if any of you have interesting cases or cases that baffle you or even slightly in any way, please contact me or Hannah, send us a little synopsis of your case and say, hey, I'd like to present this case, and we'll figure out a way to make it happen. And these are the different organizations that have endorsed this program. I particularly want to mention Project ECHO. We are using the Project ECHO template to run these programs. They have made a huge worldwide impact. ECHO does not stand for echocardiography, by the way. It stands for Extension for Community Health Outcomes. It's a program that's been run out of University of New Mexico for over 20 years. Obviously, PACES is the organization that represents pediatric electrophysiology worldwide. And if you wish to become a member, we can help you do that as well. Hart University is well known to many of you, bringing great innovative programs on pediatric cardiology learning. And then Children's Heartling may be less well known to some of you. It's a philanthropic organization trying to help children with cardiac problems around the world. So, and then we have some financial sponsors that I want to mention. Boston Scientific and Medtronic have contributed to this program, and we thank them. So with that, we'll get started today. Audience, please keep your mute button on. So keep yourself on mute. And if you have any questions or any comments, please send them via the chat, which we will be monitoring throughout the program. And with that said, I want to introduce Dr. Jennifer Shortland, who is a fellow at BC Children's, to share her presentation.
Thank you. Can you see my presentation screen?
Yeah, can do. And Jennifer, just to let you know, sometimes I'll sort of stop you in the middle of the presentation and we'll, ask for discussion, okay?
Of course, thank you. So thank you very much for the opportunity to present this case today. My name is Dr. Shortland and I'm one of the fellows at Vancouver Pediatric Cardiology Department. The case that we would like to present today is of an 11-year-old girl. And she presented to her local emergency department following a syncopal event, which occurred during a dance class. She was in the middle of her dance class. She had just performed a routine and she was walking back towards the back of the class and without any warning had a sudden loss of consciousness. And during this fall to the floor, she also sustained a significant head injury as she fell, injuring herself against one of the mirrors. And she was taken into her local emergency department. She had recovered quickly. She had a normal examination in the department. And on the history that they took, it became apparent that this was actually the third episode of syncope that she had had in the previous 12 months. The first episode actually occurred 6 months prior to this, and it was while she was in a swimming lesson. It was an outdoor swimming pool, but it was heated, and it was at the beginning of the lesson. She had no symptoms. She came round and she was on her back and being brought towards the edge of the swimming pool by the lifeguard. And she was seen in the emergency department following this. She again recovered well. She hadn't aspirated a significant amount of water. There wasn't a 12-lead ECG performed during that assessment, and her family were advised that she should avoid swimming for 6 months. And then there was a second event which occurred while she was at school. She was involved in a skipping game with her friends. She was waiting in line for her turn and started experiencing kind of tunnel vision-like symptoms, and then had a syncopal event and lost consciousness and came round on the floor. And it wasn't until this third episode during the dance class that she actually had a 12-lead ECG, which we have here. So this is her presenting 12-lead ECG at rest. And I don't know if anybody wanted to comment in the chat box of whether they thought anything was significant.
Let's stop the presentation for a moment and ask any of the experts, Andrew or Alison. So just based on the history and this ECG, what would you be thinking right now?
I think the history is particularly concerning anytime there's syncope with exertion, syncope with significant injury, syncope in a pool. All three of those episodes are really raising my red alert flag. I think the EKG looks to me really normal. It looks very much like sinus rhythm. The QT doesn't look long. There doesn't look like there's LVH. I don't see any hints of little epsilon wave or brugada pattern, but there are certainly things that can be hidden beyond just a plain normal EKG.
Andrew, what would you advise anybody coming to the emergency room if the emergency room calls you and says, hey, I have this 11-year-old who fainted in the swimming pool? Anything beyond, over and beyond the ECG?
Well, I mean, I think kind of taking a step back, as Alison mentioned, and Balaji, perhaps as you're indicating, I think the history is really key here. And so the specific events that led up to the syncope, in this case, whether it was getting ready to skip, whether it was during dance, or whether it was in the pool, that history is really where I feel like 90% of the mystery lies. In terms of workup, I agree here. I'm sort of, I do think it's notable that an ECG was not obtained prior, when in fact, I really think that's probably one of your go-to tests in the situation, relatively widely available, easy to do, can be very helpful. And I think there's probably a missed opportunity there. I agree with Alison. I think this ECG looks pretty normal, maybe a little bit of bradycardia for age, but other than that, looks very normal. The other thing potentially that you can do in that particular situation, if they have the ECG leads on, is to go ahead and try to do a brugada protocol ECG. There's about 1 million different ways to do this. I naturally think my way is the best, and any other way is wrong, but I like to take that lead 5 and V5 and V6 and place them above V1 and V2 to try to capture that right ventricular outflow tract and look for an evoked brugada pattern there. I see nothing here in V1 and V2 to make me think that if one were to do that, one would see a pattern, but it's just an easy test that's, I think, helpful in the situation when an ECG is done.
So for members of the audience, we recently did a session on brugada. So if some of you have questions about brugada syndrome, please contact me or Hannah, and we can send you the YouTube link to that or the video link to that. Sorry, Andrew, go ahead.
No, that's great. I think the other thing too, while you have the family in the room, is a good old-fashioned family history. I'd love to know a little bit more about other first-degree relatives in the family and build out from there a 3-generation pedigree, specifically asking for things like sudden death or unexplained death or early heart attacks. Sometimes families may not really know, how to express concerning history. So I think guiding them through that with some specific questions about syncope or pre-syncope or seizures can be helpful. And then there's more specific questions that can be helpful, I think, in this situation too. Has anybody ever had a shock box put in or a pacemaker put in? Anyone ever had heart surgery for any reason? Any babies ever died? And you can get very specific for sort of red flags for me in that family history or the personal history, and ask about, have specifically good swimmers ever drowned before? Specifically, has anyone been born with hearing loss that was, sensory neuro hearing loss? Those questions like that, I think, can be very, very revealing.
Just a comment about
please.
about her presentation. The only reason she attended the emergency department was because of the injury from the crashing into the mirror. So, I think the EP community and pediatric cardiologists in general have a lot of education work to do still. That someone could lose consciousness in a swimming lesson and not be referred. And this dance one really, again, was only because of the injury. So
Yeah.
Our default is often to think it's reflex.
I think Alison alluded to this, but fainting during swimming is particularly concerning for a pediatric EP. Does anybody want to elaborate? Yaniv, what do you think? While Yaniv is getting ready, question from the audience. How do you differentiate exercise vasovagal syncope from exercise syncope caused by
I'm
an
back, by the
arrhythmia
way.
history?
Sorry.
Yeah, go ahead, Yaniv.
I couldn't get to the mute button somehow.
That's okay.
Yeah, I mean, when I hear feigning with swimming, my first question is, you don't just pass out in the swimming pool without usually some pretty major concern all around, because theoretically, if you pass out in the swimming pool, you're going underwater and could potentially drown. So just to sort of let people know, it's very, very rare to pass out during swimming. And just to the question you actually asked, that is such a red flag when I hear that, that it's pretty much no way I wouldn't think to do an extensive workup if I ever heard swimming as what was happening when someone passed out.
One of the things that I find very confusing is when somebody has been exercising, let's say they've been swimming and they get out of the pool and they're walking to the bleachers or to their, where they sit, and they pass out while they're doing that. Is that exercise, is that syncope during exercise, or is that just exercise, syncope related to exercise? And should that be treated a little differently? Any thoughts, Alison?
I think that's a really good point. I certainly have seen that a fair amount, that type of a history, especially, runners who are running the race and they cross the finish line and they're exhausted, and then they kind of pass out afterwards. And I have to say, I haven't seen any studies comparing kind of post-exertional syncope, ultimate diagnostic outcomes compared to during the actual exertion. My sense is that, those who have syncope during the exertion have more pathology than post, but I certainly haven't seen any studies on that. Has anyone else?
So while somebody else gets that, so there are these, as a pediatric arrhythmia specialist, we all have these, what we call the red flags of syncope. So we already alluded to some of them. Fainting just during exercise or immediately after exercise is certainly one. And to answer the question from the audience about how to differentiate, I think it's very hard. Sometimes you cannot differentiate. And you got to assume that it could be malignant syncope of some nature and investigate it further before you can actually eliminate it. And again, going back to what Andrew said, history. Getting a really good history. Sometimes you might have to tell the parents because the parents don't know the history. You might have to get them to call the grandparents, etc. History can be really the key to this. So let me ask another question, maybe this time to Allison. With this history, 11-year-old comes in, dance class, past history, etc. Would you do an echo in the emergency room?
You know, with how easily available echo is for us, I would. Even with a normal EKG, I think I probably would. If it's 3 a.m. and there's no techs around, I don't necessarily think I'd call somebody in. But
what are you looking for on the echo?
You know, I would be looking, you know, every once in a while we'll have somebody with a cardiomyopathy present like this. So even without LVH on the EKG, we'd be looking for any evidence of, you know, maybe an asymmetric hypertrophic cardiomyopathy or something that isn't showing up easily on the EKG. Or any evidence of RV dilation and dysfunction with like an ARVC type picture. Obviously, myocarditis theoretically could cause like a, you know, an arrhythmia that could cause exertional syncope. But it sounds like there were multiple events over a 12-month period, and I didn't hear any history of any recent illness, so that's less likely.
That's fantastic. Thank you. So, you know, there are studies both in children and in adults which show about 10% of hypertrophic cardiomyopathy patients may have a normal ECG. So a normal ECG doesn't completely exclude it. What about coronary arteries, anomalous coronary arteries? Anybody specifically tell their echo people to focus on the coronary arteries in this kind of history?
It's an excellent point. I think it's certainly something to evaluate very carefully and make sure that you see both origins of both coronaries clearly. You know, if you look at the older studies by, you know, Barry Marion way back in the day, looking at, you know, athletes who die sudden cardiac arrest, there is a very large proportion of those with coronary anomalies, in addition to hypertrophic cardiomyopathy. So it's definitely something that you would not want to miss in this situation.
Thank you. So I think one of the take-home points from what everybody is saying is that you know, when the history is malignant or concerning, a normal ECG should not reassure you. You cannot look at a normal ECG like this and say, oh, this is probably nothing. This is probably just vasovagal syncope. Okay, Jennifer, take it away, please.
Thank you. So absolutely, we agree completely with the comments. We felt that this probably demonstrated sinus bradycardia for the age of the child. But otherwise, the QTC is normal. The repolarization we felt looked normal, and they have normal T-wave progression for age, and the ventricular axis is normal. There's no evidence of strain on this 12-lead ECG, and it's sinus rhythm with normal AV conduction. So some of this obviously just gone through, but we thought we'd ask this as a question of what some of the potential causes of loss of consciousness during swimming are. It's a history point that always causes a lot of concern, and obviously, as everyone's answered there, arrhythmogenic syncope is something that we would be really concerned with this patient's history that they've presented with.
I don't know if we gave the audience a chance to respond. Doesn't matter though. Let me ask the experts here. What if somebody says, you know, this kid was on the dance floor or in the swimming pool and had a seizure and is now brought to the ER with a seizure? So the ambulance person bringing the child to the ER says, well, you know, we were called to the swimming pool. The lifeguard pulled this kid out of the water because they thought this kid was having a seizure. And when we got there, the kid was seizing, but he stopped seizing soon after we got there. And now we are here in the ER. How should that be evaluated? Any differently? Peter, I see you're there in the audience. What do you think? Peter Hessline.
Yeah. This is Peter Hessline. I wasn't paying close attention, but no, I don't think I would treat it any differently. I think seizure-like activity is a frequent consequence of cardiac arrhythmias.
Yeah, we've had I've had at least one child in my career who was completely misdiagnosed as a seizure and was being evaluated by the neurologist for seizure disorder, and then sent over late and had obvious long QT syndrome. Again, had a seizure in the swimming pool. Okay, next slide, please. While you're doing that, message from the audience, we had one child presented with exercise-induced syncope and a myxoma causing LVOT obstruction. Yeah, so usefulness of echo. Good.
So this patient was referred after their emergency appointment to a local cardiologist. They had an echocardiogram which demonstrated normal segmental anatomy and preserved biventricular function. They had a normal cardiovascular examination, and they were commenced on nadolol, 20 milligrams once daily. This child, so this was kind of subtherapeutic for weight. And she was referred to a tertiary cardiologist, and she was actually referred to come and see us in our pediatric EP clinic following commencement of nadolol and her initial assessments. So when she was seen in our EP clinic, we were able to get a little bit more background on her and also her family. So this child had no other history of previous syncope other than the 3 exertional events. There was no maternal history of syncope. There was a history of pre-syncope in the father, and that was on exertion. This had been investigated as far as having a Holter performed, which was reportedly normal. And this was arranged by his family practitioner who had then retired. So the father had then essentially been kind of lost to follow-up. This Holter was normal and he hadn't been referred on for any further investigations. There were also 3 younger siblings, all of which were fit and well as far as was known. They didn't have any history that was concerning for syncope. And there was no family history of sudden death. There wasn't a history of any infants dying suddenly. And there was no history that the family were aware of rhythm disorders.
Okay.
So based on the history that we now have from this child and the 12-lead ECG at baseline, what would be the next step that everybody would do? And we've given the choice of reassuring the family and discharging the child from clinic, reassuring them but keeping them under follow-up. Would you do an exercise test as next line? Would you do a Holter or another ambulatory monitor? Or would anyone send a gene panel for long QT, CPVT, ALVC, and Brugada?
Okay, we'll give us a minute for the audience to answer, and then Hannah can show us the results of this. So far we have a negative history other than that slight thing in the father, ECG and echo being normal. Don't answer on the chat. You should be able to pick the answer in the main screen itself. Hannah, can you show the results, please? Okay, so a large proportion wanted to do an exercise test and a smaller proportion wanted to do a Holter or an ambulatory ECG monitor. Excellent. I'm really glad to see that nobody wants to send a gene panel right away. That'd be really a shot in the dark, right? Any thoughts on that? Sending a gene panel with this kind of a story, Andrew?
Yeah, no, I agree. I think the important thing about diagnostic gene testing is that you make your clinical diagnosis first, and then you use the gene panel to kind of confirm that diagnosis, but then also to try to find a biomarker that can be informative for the family. there's a fairly good and robust body of literature that suggests if you just give healthy people gene panels for cardiac genes, you're going to find a lot of stuff that you don't know what to deal with, and at a much higher frequency than the actual disease in the population. So I agree with your earlier comment, sort of a shot in the dark, and you may miss and hit something else and really kind of go down the wrong path.
Thank you. There was a question from the audience about whether it would be, whether they were justified in starting Nadolol at this point. Shu, let me ask you, what do you think? What did you think when you saw this patient about the Nadolol?
Yeah, I think, I prefer to have a target for what I'm treating. And actually, Dr. Shortland and I were talking about this recently in a different case. I have a very high threshold for starting beta blockers especially in the sort of the preteens and the teens, because once you've put a kid on it, it's almost impossible to take them off it. So, if you started for borderline QT or, suspicious syncope, almost no one will have the confidence or the ability to remove it. So I take the initiation of a beta blocker very seriously. I'd rather have them kind of sit out for a week or two while I get them seen and sorted out. So absolutely, high threshold.
Great point. Great point. I think we talked about this on the session when we talked about long QT, but I always tell my patients who come to see me for borderline QT that really there is no way to say to somebody, you absolutely don't have long QT. You can bring me anybody off the street and tell me, prove to me this person does not have long QT, and I can't do it. Everything we do has holes in it. So there's got to be a lot of thought that goes into making that diagnosis. Let's go to the next slide.
I should just go back to just the previous comment about the genetic testing. Yeah. I absolutely agree. I would not do genetic testing at this point, but I'm sort of thinking through this case. There is almost no test that I wouldn't do until I found an answer with this concerning of a story. So I'm trying to envision if every single test going forward was negative, would I then still do a genetic test? Sure. Because the story is so concerning? And I can't say yes yet, but I would certainly think about it.
Yeah, great point. Great point. Next slide. Yeah.
So we elected to do an exercise test, and this was what was seen at 6 minutes into our hospital treadmill protocol. And the patient's asymptomatic at this point. And this is their 12 lead from 6 minutes of exercise.
Allison, what do you think about this ECG, and what are you immediately thinking?
Yeah, I think this is interesting because she went from at least the EKG that you had in clinic, which showed absolutely no ectopy at all, to having a pretty significant burden at about 6 minutes here, when it looks like the sinus rate's probably around 140 based on a fusion beat, kind of close to the beginning that I see. All the ectopy that I'm seeing is monomorphic at this point, I think, although there's a little fusion. And it looks like it's probably coming from RVOT based on the axis and the bundle, left bundle morphology. But, what's particularly interesting is the fact that it seems like it's really starting up with exercise, and that this isn't just isolated PVCs, that it's already having couplets by only 6 minutes.
Fantastic. So this looks very, very concerning. The patient's starting to have a lot of ectopy as soon as you start exercising. So let's talk for a moment. But before we talk about exercise tests, there's a question from the audience. Why did we consider an exercise test rather than a Holter monitor in this patient? So I'm assuming the questioner wants to know, why didn't you do a Holter first? Why did you just take them straight to an exercise test? Any answer to that, either Jennifer or Shu?
Yeah, the patient's old enough that we can get a maximal effort, and we can get much better determinations of QT intervals and recovery, etc. I would use a Holter if the patient was, maybe 4 or 5 years old and not likely to do well on our treadmill. But but we have fairly ready access to treadmills. For people who may not be able to get, access to a comfortable pediatric treadmill test, I agree. Getting a Holter and then having them, run around and be quite active, it can be informative for sure.
I think that's absolutely spot on. I think age has to be factored in. Also, at least in our institution, by the time you give them the Holter, they go home, they wear it, they bring it back, or they mail it back, and you get it read. Easily a week has gone by, whereas you can put them on the exercise test almost right away. That may be a factor. But both of them, both are equal tests. I don't think it's like one versus the other. Sometimes it's, or very often it's one and the other. They are complementary tests. There are situations, at least that I've come across, where nothing happens on an exercise test, but then when they go out and in the real world, when they're playing sports or whatever, they provoke arrhythmias that they haven't been able to provoke in the exercise test. Next slide, please.
So we continued running this patient, and this was what we saw about a minute later. So at this point, she has developed some symptoms in terms of she's feeling quite tired. And we can see that just one extra minute of exercise, we're getting some quite different findings on our ECG.
Alison, since you took the last ECG, I'm going to ask Andrew to take this one. And then the question on the audience, maybe Jennifer, you can answer, do you use the Bruce protocol?
So I'm used to using the Bruce protocol in the United Kingdom, which is where I was before. I think we've got our own protocol here. Is that correct, Dr. Sanatani? It's the BCCH treadmill protocol. I don't know how different that is from the Bruce.
Yeah, we have a different protocol that's not quite as uphill, but we've validated against the Bruce. The kids find it a bit easier. So it's our own local protocol.
Well, I have the opposite problem to you. I find most of my kids hate the first 3 minutes of the Bruce protocol. It's too slow. So I eliminate the first stage and go straight to stage 2 of the Bruce protocol. But anyway, everybody has their own protocol. I don't think the protocol matters that much. It's important to push them hard and get them to do a really vigorous exercise test. If you're doing an exercise test, you really need to push children hard on the exercises. I tell the child and the parents beforehand that they're going to hate me by the end of it. If they don't hate me by the end of it, then I haven't done a hard enough exercise test. And doing a wimpy exercise test is not useful to anybody. So Andrew, please talk about this ECG, please.
Yeah, so if we take a step back, this is 7 minutes further into the exercise test. And the important thing here is symptoms, in addition to what the findings on the rhythm strip. And here at elevated heart rates, we see more ventricular ectopy. Specifically prior, we saw a lot of PVCs and maybe one kind of monomorphic couplet or two. Here, we see more couplets, and I think probably at least a single 3-beat run of ventricular ectopy. And another important finding here is that the morphology of the ventricular ectopy is changing beat to beat. And in some cases, you could even suggest that perhaps it's changing like 180 degrees on its axis and becoming sort of bidirectional, perhaps. Definitely a bit more polymorphic here. All of this is in the setting of this patient's history very concerning.
So right in the middle there, if you look at the bottom lead 2, there are these 2 ectopic beats that look bidirectional, as Dr. Landstrom pointed out. Shu, can I ask you to comment? And my question to you is, when you see this finding, can you just basically take it to the bank that this has to be catecholaminergic polymorphic ventricular tachycardia?
Well, I think that the combination of the story and this finding, there's nothing else that comes to mind on the differential except maybe, I haven't seen arrhythmogenic cardiomyopathy look like this. It tends, if you're going to have electrical disease, it tends to be, much more ventricular ectopy, back to the benefit of a Holter, I suppose. Bidirectional couplets and bidirectional VT are not very common. I think 25 to 40%, but they are very very specific. So when you see them, the differential really narrows down.
Thank you. Next slide, please.
So we thought we'd like to ask people at this point what you would do. So we have this concerning history. We've done the exercise test, which you've just seen. She currently is on Nadolol, but it's less than 1 per kilo. So we'd be interested to see whether people would increase the Nadolol dose, whether they would start a second-line antiarrhythmic, such as flecainide, whether they would do genetic testing on the child, or whether they would clinically screen the parents.
Okay, let's give people a few seconds to answer, maybe 30 seconds. Anna? Okay, so most people, just a slight majority, would increase the Nadolol dose, start flecainide, genetic testing, clinically screen the parents. I mean, as people who have attended these sessions before know, there's no one right answer and other answers that are wrong. In this case, probably all the answers are correct in some way or other. But Alison, what would you do?
I think that it's important, at this point, because there is bidirectional VT, I think that the clinical suspicion of CPVT has really kind of come up. So I think it's important to give the child a good chance on a real dose of beta blocker. So I think I probably would increase the Nadolol dose to about 1 to 2 bigs per kg per day.
And I would you agree that at this point you should be doing genetic testing?
Yeah, absolutely. I think, again, to confirm that diagnosis because the phenotype is there.
Yeah. Next slide, please.
Can I just I would just point out just some caution, because again, maybe only 2/3 of CPVT are going to be genetically positive, but you would not remove that diagnosis even if you were negative for a genetic variant. So the genetics really is most useful for confirming mechanism and screening relatives. But this kid, even if the gene panel is negative, she's going to carry that diagnosis.
That is a very, very important point. I'm really glad you brought it up. Thank you. Okay, would you exercise restrict? Experts.
I can make Andrea answer that if you want.
Allison, I saw you unmute first. You have to go first on this one.
All right. Go ahead, please.
It's complicated. I think there are a lot of people that absolutely would. I think 5-10 years ago, most providers would certainly restrict. In the setting of a subtherapeutic dose of Nadolol with 3 loss of consciousness events with exertion, with now complex ventricular ectopy, it's bidirectional, concerning for CPVT. I don't feel great about her playing sports until we establish that she can be safe on beta blockade or flecainide or other things down the road.
Are you saying basically then that if you put her on a much higher dose of Nadolol and say repeat the exercise test and she does not have these concerning arrhythmias, then you would release her for playing sports?
So I think it's a nuanced conversation to have, right? So I think an important thing to figure out is the risk of the child on appropriate therapy. If they're very hard to control, that risk might be higher. That risk never is 0. And I think that's the kind of entry point for having a conversation with the family, and then seeing what the family's goals are for the child and what the child's goals are. Mm-hmm. They say, and there have been families who were like, I really enjoyed ballet, but I don't see doing it for a living, or I really enjoyed swimming, but I don't feel like I want to take that risk, as you help them define. Sometimes they say, well, we're going to take a step back from those sports activities. I think it becomes really challenging when families say, no, we are all in 100%, and we are going to accept risk. And especially with a child who may or may not fully understand that risk, that's a very challenging conversation to have. But I think we get into trouble when we sort of say it's cut and dry, and that we should do things without sort of having this nuanced discussion with the family.
Alison, any other points you want to make about that?
I think that's a really, I mean, what Andrew said is great. The only other thing that I would just add, as you're thinking through, you know, whether in the future you'd ever let them exercise, I do like to have conversations along the lines of, you know, somebody who's 11 years old, maybe that's a time where the parents can kind of direct, you know, sign them up for chess club or yearbook or student council, or, you know, there might be other interests that they can pursue that might be a better fit for them long term. So I do try to introduce that concept early, knowing that, you know, I don't think I'm going to feel good about having them play varsity soccer. So in a way, it's just better to try to almost shape and form those interests into more safe activities.
That's lovely answer. Thank you. Next slide, please.
So we brought this child back 2 months later on an increased Nadolol dose. So she's now on around 1 per kilo. And we put her back on the treadmill. And this is what we see after kind of around, again, 6 minutes of exercise. And she's asymptomatic at this point. She's had no further episodes of syncope.
So can I ask how much Nadolol you're giving at this point, roughly, if you can remember?
Yeah, it's around 1 per kilo at this point.
So that's a good dose of Nadolol. And for there may be people in the audience in whose country Nadolol is not available. Shu, any ideas on what other beta blocker they should be using? Quickly.
Propranolol, I think, is your next best option. And
so you're saying a non-selective beta blocker?
Yeah, certainly. Metoprolol, atenolol are not preferably not used.
Okay. All right. So anyway, going back to the experts. So the child's on a good dose of Nadolol. They've done the appropriate thing and tested it with another exercise test, and the kid's still having BT and bidirectional PVCs. Can we go to the next slide? Is it a question slide?
Of course, yeah. So yeah, we were just going to highlight exactly what you just said, which is that she's still having some bidirectional ventricular ectopy and episodes of ventricular bigeminy. So our question is, would you change anything at this point? So she's on roughly 1 milligram per kilogram of Nadolol. I'd be interested to hear whether people would add in flecainide at this point, whether they would consider changing Nadolol for a different type of beta blocker, whether anyone would implant a ICD at this point or refer for a left cardiac sympathetic denervation.
So we'll wait for Hannah to show the results. But while this slide brings up a lot of different points on this case, so most people would add in flecainide, some would increase the Nadolol dose, and a few would implant a defibrillator. So let's talk about these points for a minute. Flecainide first. Why flecainide? Any of the experts want to go into that?
Sure, go ahead, Andrew.
No, you first.
Okay, flecainide is an interesting. It's got a really interesting use in CPVT because it directly addresses the cellular mechanism of the disease process, and so it has had good results when added to beta blockade. So that is something that I think I would probably do in this case.
Great. What about a defibrillator, Andrew? I know it's a tricky question, particularly in the context of CPVT. I'm sure we are going to talk about that more, but
yeah, especially in an 11-year-old, I think that's even trickier. I think in this particular situation, I agree that you have to make a change medically. You're not well controlled. My personal preference would be to do that medically and really make sure that we exhaust all those efforts and then think about other things prior to an ICD. I think we do have some room to go up on the Nadolol. We can in fact probably double it without really getting into trouble. Flecainide is, of course, a very helpful adjunct to this, as Alison indicated. I think ICD is way down the road and something I typically wouldn't think about at this time.
Well, there is actually viewpoint that ICDs are relatively contraindicated in CPVT? Or what is Shu? What is your thought on ICDs in CPVT?
I tend to avoid them, until it's sort of a last resort, just because of, 1 in 5 will have a fairly significant complication, including electrical storm. Arthur Vilda and Christian van der Werf just published an editorial on it, basically saying, don't put these in at all in response to an inappropriate shock leading to death, in fact. So I think it's it's a really last resort to rescue, and hopefully we get better therapies over the next 5-7 years.
I think that's what Andrew was saying, basically, but I just wanted to draw it out and say, in particularly this disease, you want to be very, very careful. And even though they may have presented with cardiac arrest, there's some mileage to avoiding an ICD and doing maximal medical therapy. Left cardiac sympathetic denervation, what is that, and how do they do it? Just a one-liner, Allison.
Sure, yeah, it's a surgical approach that can be taken thoracoscopically, where ultimately they denervate the heart by removing T1 through T4, and it can have very good outcomes in reducing major cardiac events in patients like this, especially for whom they've continued to have breakthrough syncopal or VT events despite maximal medical therapy.
I'm sure you'll touch on it in your didactic. Next slide, please.
So at this point, our genetic test for this child returns positive for a likely pathogenic mutation in RYR2 gene. So it's a heterogeneous missense variant. It's found in the N-terminal mutation, so hotspot 1. And interestingly, so this variant wasn't observed when they looked at a cohort of 60,000 unrelated individuals. So it's rare. The frequency was 0, and it had been seen once before in clinical testing in a 5-year-old who had a positive phenotype for CPVT. So based on those criteria, our genetic lab classified this as likely to be pathogenic.
Fantastic. Next slide, please.
So this girl continues under follow-up, and she's stable for several years. At 17 years of age, she presents to our emergency department. She's in gym class at school, and she's had a witnessed collapse. The school teacher reports seeing her become unsteady whilst playing sport before falling to the ground. She has CPR performed by one of the teachers for around 10 minutes. The emergency team arrives, cannot palpate a pulse, and they continue CPR for a further 2 minutes with spontaneous return of circulation before the AED is applied. So she doesn't receive any shocks, just CPR. She's admitted to our PICU, where she makes a good neurological recovery in hospital. And interestingly, the history from mum is that there's a suspicion that some doses might have been missed. She's now 17. She's becoming a bit more independent, staying over at friends' houses. And there's a worry that the compliance might not have been perfect before this event.
And by now she's on nadolol and flecainide?
She's on nadolol and flecainide, yeah.
Okay. Next slide, please.
So interestingly, this is the 12-lead ECG, which was taken in PICU. So she's off sedation, but she's not yet mobilizing. And so this is a sedentary ECG. And, obviously there's some quite significant findings on this baseline ECG at rest in this patient post-arrest.
Quickly, any of the experts want to make a comment about this ECG? Allison?
Sure. I think it's always tough to interpret an EKG after a cardiac arrest. The myocardium has been stunned. You can see prolongation of the QT, funny looking repolarization, ectopy. It's, yes, she's having different morphology. ectopy, PVCs, but I'm not sure what more to make of it based on the fact that she just had an arrest.
Yeah. So if you didn't have the whole history that you had so far, if this was the first time this child had been brought in and is now in the intensive care unit, having had a cardiac arrest, and you see the CCG, this is not going to tell you this child has CPVT. It's just everything else that has gone before that's telling you this child has CPVT, although the CCG is extremely concerning and would make you evaluate for CPVT. Next slide, please.
So we would like to ask everyone's opinion on what their next steps would be with this patient. So she's presented with an out-of-hospital arrest, playing sport on flecainide and nadolol, but there may not have been 100% compliance. So we wondered whether people would increase the nadolol, increase the flecainide, offer an ICD placement at this point, offer a left cardiac sympathetic denervation, or offer a combination of both of them.
Okay, let's see what the audience thinks. While they are answering the question going on in the chat, Andrew, this question is for you. A question was asked about such high doses of beta blocker in the presence of sinus bradycardia. And Shu answered that 25% of these patients have sinus node dysfunction and sinus bradycardia, and that should not stop you from putting them on a beta blocker. And then the question is, what is the mechanism of the sinus bradycardia or associated bradycardia? Any insights?
Yeah, I think Shu rightly pointed out the mechanism is really unknown. There is some thought that the pacemaker heart cells actually are driven by calcium, in addition to the funny current with HCN4, and that the abnormal calcium of the myocardium, of the ventricular cell, is also reflected in the sinus node. But there isn't quite a clear link between that calcium leak and sinus node dysfunction, but it's been seen multiple times in multiple different ways, so it's real. Mechanism unknown.
Okay, here are the answers are there. Most people would offer an ICD. Next is left sympathectomy, ICD plus, etc. Shu, what do you think should have been the top answer?
Well, there's one option that we didn't consider, which is, well, there's probably a few options, but the concept of an LCSD plus a loop recorder or an extended monitoring strategy. I mean, if I truly am, as I say I am, opposed to an ICD, and I have some faith in the cardiac denervation, then I could consider denervation and then putting in the loop recorder and then having that as an additional level of monitoring. The advantage of the loop recorder is if the child or the young adult at this point, if they are having a lot of arrhythmia that is in the background, non-sustained VT, or unfairly activities of daily living, they're having couplets and bigeminy, then your therapy is not effective, but you get the information without the risk of inappropriate shocks. I mean, programming we could probably do a session for PACEs just on how to program the defibrillator in CPVT. So that's that's sort of the best of both worlds in a difficult situation.
I didn't put you on the spot earlier, but maybe I should. This kid was obviously, I mean, forget the fact that she was missing doses and so on. She was being a typical teenager. But I'm surprised you let her do gym class and sports, etc., without an AED on site.
I don't know that we said specifically there was no AED on site. We have a very proactive approach to activity. I think the concept of exercise restrictions are largely not based on our understanding of physiology. The planned and anticipated sport is probably less adrenergically challenging than the sudden or emotional adrenaline. And so before Andrew can retire, he's going to have to explain adrenoreceptors to all of us and why they are so different. So yeah, we absolutely enforce a safety plan. You have to be compliant with medications. You do all the the nutrition and the hydration. You do an AED and a buddy system. So we spend a lot of time saying here's our terms. Obviously jumping out of a plane or open water swimming are not great, but even those can be accommodated with a plan and a buddy. So we have one long QT patient who loves open water swimming. We say, fine, you decide who's in the boat next to you paddling, and they make sure they can pull you out. So, it's really about making sure that the quality of life is not at the expense of our fears.
Sure. Well said. That's a great line. Next slide, please, Jennifer.
So we just wanted to bring up a few key points from this case, which has obviously been mentioned by the experts, which is that syncope while swimming is always considered an arrhythmogenic red flag. I think most people would agree that nadolol is first-line therapy if you have the access to that. Also, flecainide can be helpful for breakthrough rhythm disturbances, particularly when exercising with combination with a beta blocker. Poor compliance is an issue as our patients go into their teenage years. As Dr. Sanatani said, we give clear advice in our clinics that if doses have been missed, then these patients shouldn't exercise and they should sit out if they feel unwell, and they should have the ability to do that if they're exercising. And again, also ICDs alone are not always the answer in CPVT.
Thank you so much for that, Jennifer. This was a great presentation. I think this ends your presentation. Am I right?
Yes, it does. Thank you.
Thank you. And Alison, you can start presenting. And Andrew has his hand up. And I was actually going to ask you a question from the audience, Andrew, which is, what is the difference between bidirectional VT and polymorphic VT?
In honesty, it was actually probably just a virtual applause. But the question is a good one. I think bidirectional VT is a bit more specific, like she mentioned, for CPVT. Polymorphic VT, of course, is more of a red flag in the setting of VT as a spectrum of disease, not necessarily as specific, but concerning. So either one of those would be consistent with CPVT.
And you had your hand up. Were you going to say something else?
I was applauding. It was a great presentation.
Oh, it was not a hand up. It was a applause.
It was a virtual applause.
Thank you so much. Okay, Alison, it's all yours.
Great. Can you guys see my screen?
Yes.
Just the slides, yeah?
Yes, looks beautiful.
Great. That was a fantastic case presentation. I really enjoyed thinking it through with everyone. I'm just going to kind of summarize in general diagnosis and management approach in CPVT, hopefully to drive home a couple of the really important points that Dr. Shortland already went through. So the clinical presentation of CPVT varies, but certainly when syncope or near syncope occurs during exercise or times of emotional stress, one must have CPVT on the differential. And just kind of for fun in a way, I went through the last several CPVT patients that we've seen just to look at what the specifics were around their presentation to kind of give a flavor of what a concerning history for CPVT would look like, in addition to what you already heard, obviously. And so there was syncope during exertion with boxing and jumping rope, playing baseball, dancing, and syncope during emotional stress. And examples there were, while performing guitar on stage at a school talent show. Unfortunately, this particular patient had it all videotaped as part of the talent show. While playing video games is an interesting one because of the emotional stress with that. And then while watching a scary movie as well. The reason patients tend to present with exertional syncope is that they're experiencing polymorphic or bidirectional VT, like we talked about. Since there may be periods of cerebral hypoxia, there can certainly be a misdiagnosis of seizures. And we've had patients with CPVT who are primarily managed due to, or thought, with a diagnosis of just seizures or epilepsy. The baseline ECG is normal or just shows sinus bradycardia like we've talked about. There's normal echo, but there is progressive ventricular plus or minus supraventricular ectopy with exercise. Somebody in the chat had asked that, and very good point. I wanted to show I wanted to ask a question at this point, which is that a 12-year-old presents with fainting during cross-country running. Which of these tests is not useful?
Thank you. Hannah, can you put it up as a survey, please? Thank you. Okay, you can show the results.
Yeah, looks like everyone is kind of aligned, and that a chest X-ray really is not as helpful as the other tests. You know, this. So I just wanted to show an example of this is actually a Holter monitor. So, you know, somebody brought up a good point of doing that versus an exercise test. And in our center, it's actually very difficult to get an exercise test. So our first line usually evaluation after the EKG and echo is just to do a Zeo patch or a Holter monitor. And this is a patient of mine with CPVT who, you know, after a bit of sinus rhythm at the beginning shows that there's some ectopic atrial tachycardia, and as well as bigeminy, ventricular bigeminy. Interestingly, this was during an argument she had with her older brother, and mom could tell that she looked different and could actually see her heart beating faster. She then went on to show that she had progressive ventricular ectopy with bidirectional VT over here, and continued runs of VAT during the same period of time. Like we talked about, CPVT is caused by genetic mutations leading to myocardial calcium dysregulation. The exact prevalence is unknown, but estimated at about 1 in 10,000. There's a similar frequency in CPVT in males and females, but probands are the ones who tend to present earlier than just family members or carriers. Regardless of the proband status, it's good to know that CPVT typically presents pretty early, and this graph shows the cumulative symptom-free survival on the y-axis and age in years on the x-axis of a cohort of about 100 patients with CPVT, including, I think, 50 probands. So over an 8-year follow-up period here, there were 80% who presented with cardiac symptoms by the time they were in their early 20s. So good to know that these patients really do tend to come to, or at least tend to start having symptoms in childhood, adolescence, or very early adulthood. The first step in management, like we've talked about, really is to do a risk assessment. While we really know that CPVT is a very malignant disease overall, there are certain aspects of the history or presentation that suggest particularly high risk. And those include being younger at presentation, being male potentially, although there's some discrepancy in the data on that, having had a cardiac arrest prior to diagnosis, having already had VF or an unstable VT while on beta blockers, having persistent ventricular ectopy on exercise testing despite medical management, like the presentation we just went over, and having 2 or more genetic variants. After doing a risk assessment, the next step is to, discuss removing triggers, such as restricting exercise and which we've talked about some already, and limiting modifiable stress. Unfortunately, since it's really impossible to remove all stress in somebody's life, medication becomes an incredibly important part of managing these patients. Beta blockers are first line and are recommended for all symptomatic CPVT patients. I wanted to just show the data on the efficacy of beta blockers in CPVT. Here, this is the event-free survival on the x-axis and time from diagnosis on the event-free survival on the y-axis and time from diagnosis on the x-axis. The solid line shows CPVT patients on beta blockers, and the dotted line shows those who are not on beta blockers. So as you can see, patients on beta blockers had a significantly higher event-free survival than those who are not on beta blockers. However, even though beta blockers certainly help, it's clear that there's incomplete efficacy, since in this cohort, 27% of CPVT patients on beta blockers still had cardiac events at their 8-year follow-up time. We've talked about this already a little bit, which is, out of these options, which beta blocker is best for CPVT. And Hannah, I believe this is a poll. Thank you. Great. Seems like everyone seems to have was listening well earlier. That's fantastic. A couple of metoprolol, bisoprolol. I'll show some data on that. That's interesting. All right. But most people are answering Nadolol. Good. So let's see. The data behind this superiority of the non-selective beta blockers, such as Nadal, is shown here. In this study, they compared ventricular arrhythmias on exercise testing in CPVT patients before treatment on the left, while on beta-1 selective beta blockers in the middle, and then on Nadal on the right. And ultimately, they're showing the degree of ventricular ectopy while on each of these different regimens. It's the easy way to look at this graph is green is good, yellow is okay, orange is concerning, and red is bad. So as you can see, the proportion of patients who have good or not bad, not too bad of arrhythmia, so green and yellow, is actually significantly higher on Nadal compared to beta-1 selective beta blockers, or obviously before treatment. After beta blockers, like we talked about, another option is to add flecainide. And we talked about the fact that flecainide, the mechanism directly targets the CPVT molecular defect by inhibiting the cardiac ryanodine receptor-mediated calcium release. This again is kind of similar to the last graph, shows the response to flecainide therapy, looking at how much ectopy there, ventricular ectopy there was on standard medical therapy, meaning beta blockade, or a non-selective beta blocker, and then with the addition of flecainide. And you can see that the ventricular ectopy improves with that. So there's a class 2A recommendation that flecainide can be added on to beta blockade for patients with recurrent CPV or VT while on beta blockade. After medications, the next kind of category of the management approach is procedural. And it's hard to choose which one to talk about first because they're so kind of intertwined, but we'll talk about the ICD first. So before we chat a little bit about the data, let's pause to ask the question, what are the potential risks of ICDs in CPVT? This is another poll as well, Hannah. Great, it looks like, there's, I think, all of the above was what I was thinking with this one, but there's, all of the answers are really right, and so I know a lot of people have selected a few of the other options, and I'll show some of the data on that as well. This study by the good Dr. Sanitani's group looked at, I think, about 500 CPVT patients who received ICDs, and of those patients, 40% had an appropriate shock, yet about 20% had an inappropriate shock, 20% had an electrical storm, and 30% had a device complication. And we don't know what the impact, if any, was of any psychological distress related to an ICD, or it could be on the other side as well, related to not having one. It's just hard to know. It's hard to put that into the equation. So decision making regarding the appropriate role for ICD therapy in CPVT is very challenging. Luckily, there was a recent expert consensus that was published this year on ICD recommendations in CPVT, and ultimately ICDs were indicated in patients with a diagnosis of CPVT who experienced cardiac arrest or arrhythmic syncope despite maximally tolerated beta blockade plus flecainide and or a cardiac sympathectomy. And then there's also a 2A recommendation for ICD in combination with pharmacologic therapy with or without a sympathectomy when aborted cardiac arrest is the initial presentation of CPVT. They also say that pharmacologic therapy with a sympathectomy, with or without a sympathectomy, but without an ICD may be considered as an alternative. So again, it's a very complex decision, whether to put an ICD in a patient with CPVT. The next procedural option in terms of the management strategy is a sympathectomy. We've touched on this, but this is just a bit of a graphic showing that, that, like I said, this surgery can be done thoracoscopically and consists of removing the left thoracic sympathetic chain and paravertebral ganglia from T1 through T4. The procedure is thought to be potentially a good option and can be considered in patients who can't take or comply with beta blockers, like in the case we saw earlier, or those who can't or don't want an ICD, or in those with recurrent syncope or VT with an ICD despite maximal medical therapy. This is the outcomes of a sympathectomy in CPVT. The graph shows the incidence rate of major cardiac events before sympathectomy on the left side of the vertical line and after sympathectomy on the right side. As you can see, the number of major cardiac events decreased significantly after sympathectomy in this population who were already on maximal medical therapy and who were continuing to have symptoms. So for the right patient, this procedure can make a remarkable difference. The last important part of managing the CPVT patient is to make sure to screen the family, as the majority of inheritance is autosomal dominant, and beta blockers can be useful in treating even asymptomatic carriers of disease. So I'll end by just summarizing a few take-home points. One, consider CPVT as a diagnosis when a young person has stress-related syncope or VT, even if the baseline EKG is normal. CPVT is a particularly malignant disease, so have a healthy risk factor fear for it. And 3, beta blockers are effective at decreasing the cardiac event rates, but many patients require additional therapy. Thanks.
Thank you for that excellent summary, Allison. This was a great session. Any last minute questions? We have 2 minutes, 2 or 3 minutes left for this of the session. Any last minute questions from anybody? We've covered a rare but very important arrhythmia today, something that people need to think about. These patients can do very well on medical therapy. And so there's every reason to make this diagnosis. It can be a difficult diagnosis. One thing that I emphasize to our fellows and residents is think of CPVT as a really bad form of long QT with a normal ECG. If you have a patient who looks like they have a really, really bad long QT patient, but their baseline resting ECG is normal and does not show long QT, then you should always think about CPVT as the potential disease that they have, because it basically behaves like that. Anything to add, Shu and Andrew?
Well, thanks everybody for the discussion, and Allison and Andrew and others for their comments and questions. I think I obviously find this disease fascinating, and I guess the biggest concern I have still is right back to the initial issue. That this girl really was very close to being a unexplained sudden death in the community. 3 warning episodes. So I think the general pediatric cardiology emerge doc contributor to this condition is still still on our to-do list.
Andrew, last word.
No, just an outstanding case illustration. Lots of great teaching points and great didactics by Allison. Thank
you. Sorry, I said last word, but I have one last word, which is to thank everybody for coming, the audience, the fantastic participation on the chat feature by so many people. And we are still looking for cases to present in upcoming sessions. So please contact me if you have anything. Mohsin, thanks for attending from Pakistan. So with that, this is the last session for this year. Merry Christmas or whatever holiday you're celebrating. And we'll see you last Friday of January. Thank you all very much. Bye-bye.
Thanks, Balaji. Great year with you on this great initiative.
Thanks, you.
Thanks, Hannah, for really making him look good.
Yeah, Hannah. Without Hannah, this would go nowhere.
It's been fun.
Hannah is the key
Thanks,
person.
everybody.
Thank you. Bye-bye. Bye.